Hello, this is Dr. Fathman. We're going to do the rapid fire review for test 1, covering modules 1, 2, and 3. We'll start with diagnostic reasoning. Diagnostic reasoning is a dynamic thinking process that leads to the identification of a hypothesis that best explains the clinical evidence. It's a method of exploring a patient problem using an approach that is systematic and organized, it resulting into the generation of a hypothesis. This is systematic, it's methodical. In advanced health assessment, you all experienced how the subjective and objective data influences your thinking. What does this mean? You take all of the information, the history, the physical exam, the diagnostic testing results, and you put it together in this process. And this process develops as we grow from novice to expert. Factors that affect clinical reasoning are patient-driven and clinician-driven. Some patient-driven factors that affect our reasoning are increasing acuity of the patient, how sick are they, if they're a poor historian, any alteration in mental status, if they have multi-system disease processes, acute and chronic, multiple complaints, and or comorbidities. Clinician-driven factors include limited experience, the knowledge base of the clinician, continuous review of data and how that occurs, uncertainty of data, and demands for cost effectiveness and speed can affect this. So knowledge, context, and experience all play a role in synthesizing the data provided by the patient and family and developing the hypothesis. So as you gain knowledge and experience, that file cabinet in your brain will grow and you will develop a more systematic analysis and, in addition to that, intuition of the issues and the problems. There are specific types of knowledge, explicit and tacit. Explicit is the foundation of reasoning. Explicit knowledge can be described, analyzed, measured, and taught. Basically what you're gaining in your didactic courses is explicit knowledge. Tacit knowledge is possessed without conscious awareness. It's more intuition. It's built from a quantitative and qualitative clinical experiences over time. Tacit knowledge is integral to the entirety of a person's consciousness. It's acquired largely through the association with other people, requires joint and or shared activities to be imparted from one to another. So you'll learn, one example of this is like you learn this explicit knowledge in your didactic courses and you gain some of the benefit of the tacit knowledge of your preceptor when you actually apply this in clinical practice. Who is more than likely an expert in the area, depending on how long they've been in practice of their clinical practice. Types of diagnostic reasoning are probabilistic, causal, and deterministic. Probabilistic is based on associations between clinical data that trigger the potential presence of a disease, so the probability of A plus B plus C equals D. Causal reasoning is based on cause and effect relationship between clinical data. Deterministic reasoning depends on knowledge that exists as unambiguous rules, and this utilizes diagnostic algorithms. Diagnostic reasoning skills depend on the knowledge of condition states or diseases, information and knowledge regarding epidemiology, pathology, mechanisms, and associated clinical manifestations, and then expert knowledge of association between conditions and clinical manifestations and how they present. And then the ability to recognize the patterns in signs and symptoms of disease. So that leads us to pattern recognition, which involves the simultaneous ability to recall the pattern of signs and symptoms for a disease and the ability to distinguish between manifestations of one disease from another. So an example, dysuria, urgency, and hematuria may lead you to think cystitis, or if someone has a history of upper respiratory infection, now they have a high fever, cough, dyspnea, you may be thinking pneumonia. A sexually active individual woman with late period, breast tenderness, urinary frequency, and fatigue, you may be thinking she's pregnant. So some limits to pattern recognition include incomplete or modified presentation, a failure to communicate essential signs and symptoms, and maybe trying to fit into the symptoms into a disease, and you don't quite fit into this prototype that you have in your head. Influences include experts have prototypes that serve as a paradigm for their future cases. Heuristics are mental strategies that provide shortcuts but can lead to errors. These are like rules of thumb. An atypical presentation of common diseases occur more frequently than typical presentations of rare disease. So when in Kentucky, you think horses, not zebras. And do not expect one disease process to explain all clinical manifestations. Often there's an overlap and maybe there's comorbid conditions or more than one issue going on. Some maxims include common things occur commonly. Real disease will declare itself, so follow-up is very important. Occam's razor refers to pattern recognition and involves the simultaneous ability to recall the pattern of signs and symptoms for a disease and the ability to distinguish between manifestations of one disease from another, whereas Hickham's dictum counters Occam's razor, and so it is often statistically more likely that a patient has several common diseases rather than having a single rare disease that explains everything, which is true in clinical practice. So it's not really super likely that you're going to find just one thing that covers everything, one disease that covers everything. There's a lot of other sometimes layers that go into this, layers of disease. Hypothesis-driven strategy. So this is what we want, and so you identify the problem and generate a hypothesis. So backward reasoning is an error of novice clinicians in which the hypothesis is generated and then you try to acquire data to uphold that. So this is inefficient, and lack of knowledge inhibits construction from the data. So to construct the story as you receive it and then know what to do with that versus having an idea in your head of what this diagnosis is already and then trying to get data to fit that diagnosis. That's backward reasoning. Forward uses data or items to generate the hypothesis. It's efficient, used by expert, and it requires solid knowledge of the symptomatology and understanding of disease processes. It requires a logical analysis to develop the list of differential diagnoses. So there are different frameworks. Sometimes we use a pathophysiologic framework, an anatomical systems framework. Anatomical framework, for example, I kind of use when we discuss abdominal pain, and you'll see that when we get to that module. Mnemonics, and then a combination of these different frameworks help us with that file cabinet in our brain of these understanding of these disease processes and these associations. So you want to prioritize your differential diagnosis list according to probability, severity of disease, like what's the prognosis here and how bad would this be if we miss this, like how deadly could this potentially be, and pragmatic, which is the most practical and most responsive to treatment. You want to evaluate your hypothesis, go back through the interview, your history, your pulmonary or physical examination and diagnostic testing, and then you analyze the hypothesis to further refine and confirm your diagnosis. Selection of diagnostic testing must be based on pretest probability and likelihood ratios. So it's a Bayesian process. Utilizes sensitivity and specificity. Sensitivity asks what proportion of those patients who have the disease will have an abnormal or positive result. So sensitivity is the true positive rate. So a 100% sensitivity would mean all patients with the disease have a positive test and 0 with the disease have a negative test. High sensitivity confirms presence of disease, has few false negatives, so it's a good test for screening because fewer cases are missed. It's used to exclude diagnosis or rule out disease. Negative result means there's a low likelihood that the patient actually has the disease. Specificity is the proportion of those patients who have the disease will have an abnormal or positive result. So specificity is the true negative rate. So 100% specificity would mean that no patients without the disease would have a positive test. So tests with high specificity confirms absence of disease, has few false positives, so it's good for diagnostic testing, used to confirm diagnosis or rule in disease. Positive result means they likely have the disease. Pretest probability is the probability of a patient having the target disorder before a diagnostic test result is known. These are tests with validated scoring methods. Post-test probability was determined by Bayes' theorem in 16th century, and this provides a method to convert prevalence, sensitivity, and specificity into the probability that the patient has disease. So in other words, the probability of the patient having the disease after the results are known uses odds likelihood ratios, and these are nomograms. So you think about the probability that a positive test result will be associated with a person who has the disease, that's referring to sensitivity. The probability that a negative result will be associated with a healthy person who does not have the disease, that's specificity. A likelihood ratio above 1 indicates a positive result associated with disease. Likelihood ratio below 1 indicates negative result associated with the absence of disease. Likelihood ratios that approximate 1 or near 1 provide weak evidence for the test's ability to identify with or without the disease. Likelihood ratios above 10 and below 0.1 provide stronger evidence, so the further they are away from that number 1.0. The goal of diagnostic testing is to decrease false positives and false negatives. Utilizing Bayesian principles in consideration of ordering diagnostic tests. You don't want to order a test if you are not prepared to manage an abnormal result. We're going to move on to imaging. So we're going to talk about ultrasound, CAT scan, CTA, MRI, MRA, and nuclear med tests, SPECT, and PET scans. Ionizing radiation exposure is the biggest concern for X-rays and CTs. CT accounts for the majority of imaging exposure in the United States. Radiation exposure accumulated over the years increases risk for malignancy, so the concern here is risk for cancer down the road. The electromagnetic spectrum, along that spectrum, X-rays and gamma rays are at the highest end of the energy spectrum, and the lowest end of that energy spectrum are radio waves. The American College of Radiology appropriateness criteria provide evidence-based guidelines to help providers with ordering imaging tests. An example recommends transabdominal and transvaginal ultrasound as preferred initial imaging and pelvic MRI with and without contrast if the ultrasound is inconclusive or further imaging is characterization is needed. Ultrasound is a non-invasive best choice for initial imaging if the area in question can be visualized with the ultrasound. It can be done externally and internally. Diagnostic anatomical ultrasound provides images of organs and structures, and functional ultrasounds are also an option. An example of a functional ultrasound would be a Doppler flow of blood in the coronary arteries, where it actually shows the flow of blood. Functional ultrasound is focused high-level output to heat, ablate, or break up the tissue, but you need intact skin and tissue for this test, whether it's internal or external. There are no absolute contraindications to ultrasound, and the sensitivity and specificity varies by the problem. It's a high sensitivity specificity for ultrasound in diagnosing carpal tunnel syndrome, carotid artery stenosis, and acute pulmonary edema, as well as deep vein thrombosis. When we look at body planes, there are different planes. The sagittal plane is right-left, divides right and left on the vertical plane. The coronal divides the front and the back on the vertical plane. The axial body plane divides upper and lower on the horizontal plane. CAT scan images are viewed as slices, creating cross-sectional images. These are most effective for viewing bone and soft tissues. Blood vessels show soft tissues better than X-ray. This is quick and effective. It's the top choice for emergency imaging. For neurospecific, it can be really good for brain damage after a trauma, hematoma, bleeding, bone fractures, hydrocephalus, inner ear and sinus imaging, spinal stenosis, herniated disc, spinal cord, and vessels. CT images are described in terms of density. Hyperdense is bright and represents blood and calcifications. Hypodense is dark, represents edema and infarction. An acute hemorrhage shows as hyperdense, which is white. Subacute bleed, isodense, which is gray. Chronic hypodense would be dark to black. So areas of ischemia darken over time, so they become more hypodense. There are contrast agents used in CT, and this helps differentiate tissues to expose pathological lesions. The contrast is contraindicated if the patient has a history of allergy to the contrast, if they're pregnant, or if they have had a prior treatment with radioactive iodine. if they have chronic or acute kidney disease. Some indications for CAT scan: acute head injury, suspected subarachnoid hemorrhage, ureteral calculi, acute cervical spine trauma, suspected appendicitis in the non-pregnant patient. Basically, CT is quick, it's effective, and it's the top choice for emergency imaging. It is costly and it has high radiation content. Contraindications to CAT scan: pregnancy, especially first trimester, IV contrast. Contraindications include renal impairment, particularly if the glomerular filtration rate is less than 30 mLs per minute, if they have an allergy to the contrast, if they have hyperthyroidism with goiter, if they've been treated with radioactive iodine, if they have a pheochromocytoma, myasthenia gravis, you have to use caution. And as a note, you need to hold metformin for 48 hours after administration of any IV contrast because of the impact on the kidneys. Non-contrast indications, meaning without contrast: CT, brain trauma, headache, bleeding, sinus pain, congestion, sinusitis, and any orbital trauma or foreign body, facial bone trauma. So basically traumas you don't want to add contrast, right? You don't know where those might go. Chest nodules, cough, pain with a cough, abdomen and pelvis, if there's painful hematuria or a stone, to evaluate that. Any spinal pain, trauma, fracture, extremity fracture, fusion, malunion, pelvic trauma, fracture, or pain. Indications for CT with contrast include an orbital infection or mass, neck mass or adenopathy, chest mass including metastatic cancer, lymphoma, sarcoid, abdominal and pelvic pain, colitis, Crohn's, appendicitis, tumor, cancer, or mass. Sometimes they'll do CTs with and without contrast, and some indications for this may be acute appendicitis, cancer staging, diverticulitis, pancreatitis, or pulmonary embolism. There's pre-medication available for prophylaxis for prior iodine contrast reaction. This includes methylprednisone 32 milligrams orally 12 and 2 hours before contrast administration, with Benadryl 50 milligrams IV, IM, or PO 1 hour before contrast administration. Or you could give the same Benadryl with 50 milligrams of prednisone, PO 13/7 and 1 hour before contrast administration. CAT scan's preferred over MRI for bony clarification. It gives you better bony definition for calcifications or ossified abnormalities. If it's an emergency, you need something quick. It is better at detecting early intracranial hemorrhage and subarachnoid hemorrhage than MRI. It's quick, it's cheap, less problems with claustrophobia, better for unstable patients, and generally it's good for the 3 Bs: blood, brain, bone, and particularly those in emergency situations. CTA is CT angiography, uses standard CT technology, which is an X-ray base, to view the blood vessels. So contrast dye is given intravenously. This is less invasive than traditional angiography. It's more patient-friendly. In 1994, it began to replace traditional angiography. Radiation and contrast exposure are the biggest concerns. So after the images are acquired, a computer processes the images, making it possible to display them in different ways, shows cross-sectional slices, 3D casts, or a cinema loop, like a movie. Used to rule out PEs, rule out renal artery stenosis, aneurysms, dissection of aorta and major branches, AV malformation, pulmonary artery disease, and exclude coronary artery disease. The new coronary CTA is a useful risk assessment tool for coronary artery disease. Contraindications to CTA: severe ionized contrast allergy. In the new 64-row scanners, gadolinium, which is used for MRAs, is an alternative. So that's something that something to think about in the newer scanners. But typically, it is the ionized. They use iodinated contrast for CT contrast imaging. If someone has azotemia or renal insufficiency, so always think kidneys when you think contrast. So if they have kidney disease, you're going to take a look at that and see if it's the risk, evaluate the risk and benefit. Small vessel occlusive disease, CTAs are unable to evaluate arteries less than 2 millimeters in diameter, so if you're suspicious of that, it's not going to be a good test. Dense, extensive mural calcifications of Muckbird's medical sclerosis, which you see in diabetes and chronic renal failure, will impede view of arteries less than 4 millimeters. In summary, the risks of CT are radiation exposure, which can damage body cells. This is 100 to 1,000 times higher than the exposure of conventional X-rays. The younger you are when you're exposed, the higher the risk. And any history of adverse contrast reaction, of course, and then you want to think about any risks associated with radiation overdose. MRI uses a magnet, radio waves, and a computer to detect different water concentrations in tissues. The body is viewed as a slice, like a loaf of bread, 1/4 inch thick, creates cross-sectional body images. They can be 2D or 3D and provides very detailed images of soft tissue. So this is exquisite contrast between normal tissue, especially like in the brain, between white and gray matter, and pathologic tissue. It involves no ionizing radiation compared to CT. And then signal images for MRI are interpreted in terms of signal intensity. So hyper intense is more intense. So if an abnormality is bright white on MR, we describe it as hyper intense. Hypo intense is less intense. If an abnormality is dark on MR, we describe it as hypo intense. Iso intense would be the same intensity. An abnormality has the same intensity to a reference structure. We describe that as iso-intense. Air and hard bone appear black. Bone marrow, spinal fluid, blood, and soft tissues vary in intensity from black to white, depending on the amount of fat and water present and the sequence. So common imaging sequences of MRI are T1, T2, FLAIR, DWI, gradient echo, T1 with contrast. You do not need to know those for the test. Diffusion refers to technique of interpreting the MRI image in terms of the measurement of movement of molecules through tissues. Diffusion is decreased in acute ischemia. This helps to diagnose acute infarction, such as a stroke. MRI contrast is gadolinium, used most commonly in MR angiography. This crosses the placenta and is excreted in breast milk. There is a low risk profile associated with gadolinium contrast and lower incidence of nephrotoxicity compared with the iodine contrast used for CAT scans. So chronic and in end-stage renal disease, so it is contraindicated, in end-stage renal disease patients with a glomerular filtration rate, a GFR less than 30 mLs per minute. There's a risk there of nephrogenic systemic fibrosis. Benefits: you get, as I mentioned, exquisite soft tissue contrast, particularly in the brain. Customized imaging techniques can answer specific questions. There is no ionizing radiation. You can directly image in any plane. You can do a functional MRI. It detects a multitude of diseases. It's very good for neuroimaging. Cardiovascular, you can identify MI, cardiomyopathy, tumors. Musculoskeletal can show soft tissue tumors, spinal imaging, and joint disease. In the GI system, you can pick up lesions of the liver, pancreas, and bile ducts. And for oncology, it's often used for staging of rectal and prostate cancer. Disadvantages include higher cost, limited access. Not all locations have MRIs. It's difficult for unstable patients because it takes a long time and you have to hold still. Patients with claustrophobia, not really good candidate for this test because you're inside this little donut. Absolute contraindications, there are some, and I'll go over those in just a sec. It's not as great for bony detail if the body size could be too large to fit into the machine. It's very loud, and certain implants cannot be scanned, and metallic artifacts can blur or skew the images, rendering them less helpful or totally inconclusive. Contraindications of MRI. Cardiac pacemaker or artificial heart valve, metal plate, pin, or other metallic implant, intrauterine device such as a copper 7 IUD, some aneurysm clips, previous gunshot wound, inner ear transplant, neurostimulator, port for delivering insulin or chemotherapy, if they've been a metal worker and had metal in the eye, permanent eyeliner or tattooing, and not recommended in first trimester of pregnancy. If a patient has severe claustrophobia, you have to remove leggings or yoga pants. Some, particularly Lululemon brand, contain metal fibers that can burn the patient. MRI has a benefit over CT in that there's no radiation exposure, provides better anatomical definition, particularly of the posterior fossa in the brain, no iodine-based contrast. There are also more sequencing possibilities to tailor the image to the specific tissue type. MRA uses standard MRI technology. Gadolinium contrast helps the computer to see arteries and veins, and it shows blood vessels, particularly in the neck and brain, very well. Commonly used to rule out aneurysms, dissections, embolus, and atherosclerosis, has the same contraindications as MRI. So there is advanced MRI technology, including functional MRI, which uses a high Tesla MRI machine detecting both structure and function. It observes brain function and creates sort of a map of brain organization, and while the patient is performing a particular task. It determines precisely which part of the brain is handling functions such as thought, speech, movement, and sensation. The information is critical in planning surgery, radiation therapy, treatment of stroke, and other interventions. Image-guided surgery with the help of the computer and intraoperative position sensing system, reconstructed images can be presented, allowing for accurate, dynamic, interactive 3D localization of surgical targets and trajectories. It's kind of like a GPS for surgeons. Nuclear med scans. These play a complementary role when other imaging studies are negative or inconclusive, but when there remains a strong clinical suspicion of a bony abnormality. Nuclear medicine uses the tracer principle. Scintigraphic images are produced following the administration of radiopharmaceutical. The radiopharmaceutical distributes through the body based on its chemical and biological properties. Radiation, mostly gamma photons, emitted from the agent are converted into planar or tomographic images. And the unique aspect of this is that radio tracer localization reflects molecular, metabolic, physiologic, and or pathologic conditions. So the type of scan depends on the clinical indication. Bone scan is the most common nuclear imaging exam used to evaluate joint conditions. The greater acuity and severity of an inflammatory process generally results in findings of more increased blood flow and blood pool activity on the 3-phase bone scan. So it's generally recommended to wait at least 24 hours after the initial injury before considering a nuclear scan. PET scan is an important modality for evaluating metabolic activity of tumors, so we can see cancer follow-ups are often. PET scan is often used for that. So let's move on to chest x-ray. You want to look at the whole picture, understand what each color represents, and make sure the film is optimized or adequate, and consider the views for the best interpretation of the clinical picture. So you want to review the surface anatomy, including the tracheobronchial tree, the spinal column, the clavicles, location of the upper and lower lobes, the right and left hemidiaphragm curve. The right is always a little higher due to the liver. That's a normal anatomical finding. And the heart, anterior, posterior ribs, aortic knob, left and right hilum, and the aorta. You want to recognize it. You can't recognize an abnormality if you don't know what you would see normally or what you would normally expect. Remember densities in x-rays. The blackest part of the x-ray is air, fat is dark gray, soft tissue is gray, anything man-made like metal is going to be bright white, calcium bone is white, and you can see the demarcation of lighter appearance in cases of pneumonia with consolidation. So the x-sheet gives it density. The optimal chest x-ray will have a magnification. And so when we talk about magnification, the anterior-posterior versus posterior-anterior effect. So the standard is posterior-anterior, in which the heart is closer to the film, thus less magnified for a better view. Anterior-posterior, heart is farther from the film, more magnified. Portable chest x-rays are almost always done anterior-posterior, which they're not as great, but sometimes when patients are critical, you don't really have a choice. So we think about angulation. Apical, lordotic is when the beam is angled up toward the head. It gives a larger appearance of the heart. So you have to consider the views when you're interpreting the finding. Not lordotic is preferred to get a better view, and the clavicle should be over the third rib. Penetration and depth of inspiration. If penetration is adequate, you should be able to see the thoracic spine through the heart. You should see the sternum plus 2 sets of posterior ribs. If it's underpenetrated, it'll look too white. Overpenetrated, it'll look too dark, and you won't be able to see all the structures. Inspiration is best when you can see 10 posterior ribs. Poor inspiration clouds markings and may lead to a false reading of airspace disease. Rotation and centering is very important. Is the patient centered? The spinous process of the vertebral body should be equidistant from the medial ends of each clavicle. The trachea should be midline and the clavicle should be over the third rib. Some body habesis may impact some of the technical factors of getting a good chest x-ray. A lateral chest film allows visualization of abnormalities hidden in the posterior anterior view, hilar region, and anatomic landmarks. Not a lot of lung tissue is visible, but 200 to 400 milliliters of fluid in the fluid space will be there before it can be seen on the frontal films, whereas the smaller effusions, 30 to 50 mLs, can be visualized on the lateral view. So that is an advantage of the lateral view, is to be able to see smaller pleural effusions. Right lateral decube is when you're lying on the side, and it helps to see pleural effusion and air fluid levels. The lordotic view views the upper lobes and apices, is really good for cancer or tuberculosis. There's Amarosa's 8-step approach to review, which includes paperwork, outside the chest, soft tissues, bones, pleura, and mediastinum, lungs, and then you make your conclusions. So it's important to just know those steps. Within the pleural, that's where the meat of the matter is. So these are some abnormalities that we see. Curly B lines are thickening of interseptal lines. They are perpendicular to the pleura, and they're seen in heart failure, indicates excess fluid. Air bronchograms are when bronchus becomes visible in cases when fluid or density fills the alveoli. So air in the bronchus becomes visible. It occurs with pulmonary edema, if there's blood there, gastric aspirate, or inflammatory processes. They look like tubes because the surrounding areas are full of some form of exudate. When two objects of the same density touch each other, the edge between them disappears. This is present when water density obliterates the existing interface. It's used to differentiate anterior, posterior, and right-left-sided landmarks. So an example would be the left lower lobe silhouettes the hemidiaphragm. Alveolar infiltrate. These look like fluffy white clouds. There's fluid in the alveoli, and this is present in pulmonary edema. You see indistinct margins, confluent, homogeneous, and air bronchograms. Interstitial infiltrates are small, well-defined. They're reticular, which is like a net-like pattern, nodule, or reticular nodular, might have bits of both opacities due to the fibrosis, fluid, or inflammatory byproducts. You may also see honeycombing. So interstitial lung disease would be seen as discrete and homogeneous, which means not uniform in character or content. There are no air bronchograms. Reticular lines, you could have reticular lines or nodules or both markings, and curly B lines, which you may see with cancer, sarcoidosis, CF, and asbestosis. Consolidation results from replacement of air in the alveoli by transudate, pus, blood cells, or other substances, so think of pneumonia. X-ray findings include ill-defined homogeneous opacity obscuring the vessels. You might see a silhouette sign, air bronchogram. There's typically no volume loss, and it extends to the pleura or the fissure, but it doesn't cross it. The consolidation is very well demarcated. Whereas diffuse lung patterns involve both alveolar and interstitial spaces. So heart failure with pulmonary edema, ARDS, the adult respiratory distress syndrome, atelectasis, which can include loss of lung volume, pneumonia, which you see airspace disease and consolidation, not associated with loss of lung volume. Tuberculosis typically is seen as a consolidation, adenopathy, and pleural effusion, focal patchy airspace disease with cotton wool shadows, cavitation, fibrosis, nodal calcification, most common in the posterior segments of the upper lobes and the superior segments of the lower lobes. Cavitation can be seen in carcinoma in cases of cancer. You see a thick wall, a nodular inner margin. In TB, it's thin-walled and there's no air fluid level. In an abscess, it's thick-walled and smooth, but there's fluid in there. A benign lung cyst has uniform wall thickness, about 1 millimeter, and a smooth inner lining. Indeterminate cavities could be 5 to 15 millimeters, mildly irregular inner lining. Pulmonary fibrosis shows honeycombing cyst, reticular septal thickening, and subpleural and posterior basal predominance. Emphysema shows diffuse hyperinflation, flattening of the diaphragms and the hemidiaphragm, increased retrosternal space, bullae, cylindrical or vertical heart, and sometimes the trachea is narrowed. A mass lesion-like cancer looks like homogeneous, sort of a liquid density or opacity with very sharp margins, in contrast with the air-filled lung. It's usually round or oval in shape, and it crosses over fissures. It does not respect the borders. Whereas in something like histoplasmosis, the calcifications are not as sharply defined, non-cancerous calcifications, which calcifications are non-cancerous. So the mediastinum, there should be the chest to thoracic ratio is 1:2. So heart should be no more than 1/2 the width of the chest. So the CT ratio greater than 1:2 suggests cardiomegaly or an enlarged heart. And then you, of course, want to look at the lungs and make your conclusions is the last step of Amarosa's approach. All right, moving on to pulmonary function testing, the last lecture on this test. So the purpose of pulmonary function testing is to provide acceptable, which is quantifiable, and repeatable measurement of lung function. To diagnose lung disease, screening, assess pre-op risk and prognosis, measures response to treatment, disease progression, status, particularly after exposure to toxic agents. It helps to evaluate disability or level of impairment, also used for research purposes, and to assess baseline or pre-procedure risk. Volume is static. It's a single measurement with no time involved. So some of these measurements include vital capacity. So this is the maximum volume exhaled after maximum inspiration. It can be measured during a forced exhalation, forced vital capacity, or slow exhalation. Functional residual capacity, FRC, is the volume of air remaining in the chest at the end of a tidal volume breath. So this is regular breathing after a normal breath. It is what can be blown out after normal exhalation. Residual volume is the amount of air remaining in the chest after maximal exhalation. So this is forced, which keeps the alveoli open. So we would expect a larger residual volume in patients with emphysema because of trapped air. Expiratory reserve volume, ERV, is the volume of air exhaled from end tidal volume. So FRC to the point of maximal exhalation, the residual volume. Inspiratory capacity is the maximum inspiration from end tidal volume to total lung capacity. Total lung capacity is the volume of air in lungs at end of maximal inspiration. And this is usually calculated by residual volume plus vital capacity or functional residual capacity plus inspiratory capacity. So this is also going to be higher in someone with emphysema because of that air trapping. Spirometry measures the forced vital capacity maneuver, the mechanical function of that lung to snap the air out. The three most important indices derived from spirometry are 1, the forced vital capacity, which is the FVC. That's the total volume of air exhaled. 2, the forced expiratory volume in 1 second. That's the FEV1. The third is the ratio of the two, the FEV1 over the FVC. Bronchodilator response, such as albuterol, uses albuterol. So if you want to address reversibility or understand that, you must order a pre-post test to see if there's a change in the mechanics of the air getting out. So if you have a baseline, you give something like albuterol, if you want to, in order to diagnose a reversible airway obstruction, you must see at least a 12% improvement in the pre and post test. And so you're going to request this if you see an obstructive pattern on the baseline spirometry. The flow volume loop measures inspiratory and expiratory flow on the y-axis against the volume on the x-axis during the performance of a maximally forced inspiratory and expiratory maneuver. The diffusion capacity of carbon monoxide, DLCO, measures the ability of lungs to transfer gas from inhaled air to red blood cells in pulmonary capillaries right at the alveolar interface. In asthma, DLCO is usually either normal or high. Higher DLCO, the higher the severity of asthma. So this can help differentiate asthma and emphysema. So the normal DLCO is 80 to 120% of the predicted. In emphysema, interstitial lung disease, pulmonary fibrosis, hypertension, pulmonary embolus, lupus, anemia, the DLCO will be decreased. DLCO is normal or increased in asthma, bronchitis, pulmonary hemorrhage, exercise, and laying in the supine position. Bronchoprovocation testing, you may need the challenge antigen given. You give a challenge antigen to assess the airway hyperresponsiveness to diagnose asthma in the setting of a normal baseline spirometry or pulmonary function test. So this is kind of the opposite of the pre-post test, in which you have a normal baseline, you administer something that may provocate the obstruction, like methacholine or histamine. So that test is positive in this case, in the bronchoprovocation testing or a methacholine challenge, when the FEV1 decreases by more than 20%. So there are acceptability requirements for adults and children for spirometry. So one, a good start of exhalation with a minimal extrapolated volume, whichever is greater. It needs to be free from artifacts, no cough in the first second of exhalation, no glottis closure or abrupt termination, no early termination or cutoff. It has to have a maximal effort provided throughout the maneuver and no obstruction in the mouthpiece. So there's sometimes patients, when they're blowing out, will stick their tongue in and kind of pop it like a spitball, and that gives a false elevation. So you can kind of tell that on the test as you get better at interpreting these. So valid spirometry tests are both acceptable and reproducible. Acceptability, how do we determine this? You look at the curves. Do the curves look error-free? You look at both the flow volume and the volume time curves, and are they similar? And are there 3 good efforts? If yes, then you can determine if it's reproducible. Reproducible asks if the FVC and FEV1 variances are below 150 milliliters. So the 2 largest FVC have to be within 150 milliliters of each other, and the 2 largest FEV1 within 150 milliliters of each other. There are 4 key variables to determine the percent predicted equations for lung function: age, height, gender, and race. These are according to the NHANES 3 reference values, and these are used most commonly. The results are reported in terms of percent predicted value, or the observed value divided by the predicted value. 80 to 120% is normal for all of these, including the DLCO. FEVC and FEV1 are normally greater than 80% of predicted value. That is normal. Normal decline in FEV1 is 20 to 50 milliliters per year after the age of 19, whereas in COPD we see a decline of 50 to 80 milliliters per year. Obstruction is much more common than restriction, they're caused by a process that obstructs expiration of airflow. Differential diagnosis for obstructive disease include asthma, COPD, which is chronic bronchitis and emphysema, cystic fibrosis, bronchiectasis, bronchiolitis, upper airway obstruction. Typically you see low FEV1, low FEV1 FVC ratio, and a normal FVC. FVC can be reduced if there is a very severe obstruction. So remember, obstruction is an expiratory problem. COPD, which includes asthma, chronic bronchitis, and emphysema, bronchiectasis, CF. Total lung capacity in obstructive disease would be expected to be greater than 120% of predicted, residual volume greater than 120% of predicted, decreased FEV1 FVC ratio less than 70% of predicted, decreased FEV1, and that's how we clarify severity of COPD, normal functional vital capacity, decreased DLCO, and a concavity of the descending limb of the expiratory flow volume curve. Restrictive diseases are rare and always warrant referral to pulmonology. This is caused by a process that restricts inspiration, decreasing all lung volumes and capacities. So these include things like interstitial lung disease, severe scoliosis, neuromuscular disease. You suspect this with a low FEV1 and a low FVC, which both of those being low gives you a normal ratio. So you need the pulmonary function test lab to confirm this. So it's a restrictive disease, reduced lung volume, and inspiratory problem. Intrinsic lung disease, pneumonitis. Extrinsic disorders include obesity, scoliosis, pectus excavatum, and pregnancy. There are also neuromuscular disorders that cause restrictive defects, including muscular dystrophy and ALS. So total lung capacity would be expected to be less than 80% of predicted in restrictive disease, and the residual volume less than 80% of predicted. You see a decrease in the FVC, a decrease in the FEV1, and a normal ratio. Severity of disease based on FEV1. So if you have a low FV, start with a low FVC, and the ratio less than 70%, mild obstruction would be considered greater than 80% FEV1 of predicted. Moderate obstruction is 50 to 79% of predicted FEV1. Severe is 30 to 49% of predicted, and very severe is less than 30% of predicted, and that's the FEV1. That's how we determine severity of COPD according to the GOLD guidelines. In emphysema, we see FEV1 FVC ratio less than 70%, a scooped flow volume curve, total lung capacity is increased residual volume, and decreased DLCO. In chronic bronchitis, we see less than 70% ratio, scooped flow volume curve, but in normal total lung capacity, normal to increased residual volume, depending on where they are in the continuum of that, because emphysema, remember, is more severe obstruction than chronic bronchitis. Usually the DLCO in chronic bronchitis is normal. Asthma, we see the FEV1 FVC ratio could be normal or decreased. DLCO can be normal or increased, and you may have normal pulmonary function tests in asthma, which requires the bronchoprovocation with the methacholine challenge. So that ends the review, not so rapid fire review, for test 1. Thank you.